are just signing on. We had two really wonderful presentations, and our next presenters are Diane and Angelita from the International Association of Forensic Nurses, and both of them are forensic nursing specialists, so we're very excited to hear them. And their presentation is entitled Supporting Your Clients Experiencing IPV. So take the floor.
Thanks, Nicole. My name's Diane Daiber, and I'm going to start with the presentation, and then Angelita will pick up. I did want to take a moment to acknowledge the Office on Violence Against Women has supported this presentation, the development of this presentation through their grant funding. Of course, the opinions, findings, conclusions, and recommendations expressed are those of the authors, not of the Department of Justice or Office on Violence Against Women. So at the completion of this presentation, participants will have an increased knowledge of intimate partner violence and how to support their clients experiencing IPV with a trauma-informed response. So we wanted to start out with a poll question, and you can just put your answers into the chat. The question is, please select which of these best describes your role, whether you're an advocate, mental health provider, case manager, protective services, law enforcement, or healthcare clinician. And Angelita, if you can kind of, I can't see the chat right now.
It's okay, you actually had lost me for a minute. I got booted off and I'm back now.
Oh.
So,
okay.
Let's see.
Oh, I can see.
That's okay, I'm here.
Okay.
So we have quite a vast array. We got advocates, we have several advocates, several case managers, lots of mental health providers. Looks like we have a couple healthcare providers.
Oh, good.
Only thing I don't see anyone from protective. Oh, got someone from protective services here. And I don't see any law enforcement, so.
Okay, great. Well, feel free to put your questions into the chat too during our presentation. Angelita and I are very well aware that you are all experienced in your field, and that you recognize that violence is a healthcare issue, and that you understand the consequences of violence. It's also a public health crisis. So one of the best ways to understand the public health model is through the parable of the fisher folk who were fishing on this beautiful stream. And as they were spending their lovely day fishing on the stream, a person came floating down from upstream who was near drowning. And so they saved him. They went in and saved him. And then the next thing you know, there was another body coming down and another one. And so the fisher folk decided they better go find out what the heck is going on upstream. And when they went upstream, they found that there was a beautiful cliff to look over at the stream, but there was no fence. So the fisher folk built the fence. Now, I'm sure many of you have heard this parable before, but I think it's worth reminding people of how important it is to think about putting our resources and a lot of our energy upstream when there's a problem, and preventing, and potentially preventing the need for the intervention once the problem has occurred. So that's the essence of the public health model. And so during this presentation, I just would ask you to think about how our communities can invest in upstream resources and versus just responding to the problems. Because I know, you guys have, especially you mental health professionals, have plenty of work as a result of violence in our community. So we're going to just kind of, I know you're experts, but we just did want to go over a little bit of some of the background on intimate partner violence. And you can see here that it's defined as physical violence, of course, but we have to put in sexual violence. It's part of the definition of IPV, and you can't ever talk about IPV intimate partner violence without talking about sexual violence. And stalking is part of the definition, and which is a pattern of repeated unwanted attention and contact by a partner that causes fear or concern for one's safety. And also psychological aggression. So that can be verbal and nonverbal communication with the intent to harm another person mentally or emotionally, and or to exert control over another person. So oftentimes as clinicians, we would say we felt that the psychological aggression was oftentimes more damaging than the physical violence, because those wounds take a lot longer to heal. So intimate partner violence can occur among heterosexuals or same sex couples and doesn't require sexual intimacy. So sexual violence, like I said, is very much intertwined with intimate partner violence, so it must be included in this discussion. Sexual violence may include both penetrative and non-penetrative acts, and as well as non-contact forms of sexual violence. And it can occur in person, online, or through technology. So as healthcare providers, we usually use the term sexual assault as it incorporates various forms of non-consensual sex acts. Rape is oftentimes considered more of a legal term because there are very specific definitions that have to be met and proven in the criminal justice system. Sexual harassment includes unwanted sexual advances, including demanding sex in return for favors, sexual comments, spreading sexual rumors, and the unwanted or coerced sexual contact may be physical or coercive force, and it may include oral copulation or penetration of the vulva, which is the female genitalia, or anus. This also includes situations where the victim is forced to penetrate someone else. In Ohio, there is a law against marital rape or marital sexual assault, and our statute says no person shall engage in sexual conduct with another when the offender purposely compels the other person to submit to force or threat of force. It also includes sexual assault if the person is unable to provide consent. For example, mentally disabled or children, or if the person is intoxicated. Non-contact unwanted sexual experiences include acts such as unwanted exposure to sexual situations such as pornography or voyeurism, exhibitionism, unwanted filming or taking and disseminating photos of a sexual nature of another person. It can also include things like forced marriage, reproductive coercion, virginity checks, and of course, human trafficking or sex trafficking, which I think is the next lecture on this presentation. At this conference. So the incidence of intimate partner violence, while we know that men are also victims of intimate partner violence, but globally the burden is borne by women. So as far as the World Health Organization, they estimate globally about 1 in 3 or 30% of women worldwide have been subjected to physical and or sexual intimate partner violence or non-partner sexual violence in their lifetime. In the US, 1 in 4 women and 1 in 10 men experience sexual assault, physical violence, and or stalking by an intimate partner. And unfortunately, all too often in the news, these statistics jump out at us. So 1 in 5 homicides are committed by an intimate partner, and half of female homicides are committed by a current or former male intimate partner. So we as healthcare providers or professionals that work in a caring and helping profession cannot ignore that violence is a healthcare issue. I would guess, only because I've worked with a lot of psych nurses, that many of your clients have experienced sexual violence, intimate partner violence, and it's a matter of, which came first. Did they have mental issues and that made them more vulnerable, or has the abuse affected them and caused their mental and behavioral issues. So there's acute and long-term healthcare consequences. We're all pretty familiar with that. But we also need to think about the cost of it, intimate partner violence and sexual violence on the healthcare system, the cost to work and the loss of productivity, as well as the criminal justice costs. It's interesting that a few years ago, the CDC developed a technical package called the Preventing Intimate Partner Violence Across the Lifespan. And it's a very interesting community-based package that can be, kind of used as a guide to help promote prevention of violence in your community. So World Health Organization has this interactive map. You can find it at this site, and it is very interesting to show the amount of intimate partner violence in the different areas. So this data was drawn on a population-based, nationally or subnationally representative surveys that were conducted between 2000 and 2018 from 161 countries. So in addition to adult violence, we need to think about our teens. So dating violence during adolescence is a form of intimate partner violence, and it's considered an adverse childhood experience, or an ACE. Now, I'm going to assume most of you know what the ACE study is. It was first done by Vincent Felitti out of Kaiser, California, and Robert Anda out of the CDC, and it recognizes that specific adverse situations are correlated with negative health outcomes later on in life. So more recently, there's a lot more research coming out about the ACE studies, and Dr. Nadine Burke Harris has a book called The Deepest Well. She also has a great YouTube video. You can find information on the ACE study very easily with a quick Google search. Teen dating violence can set the stage for problems in future relationships. Intimate partner violence, sexual violence, perpetration, and or victimization throughout life. Youth who are victims of dating violence in high school are at a higher risk for victimizations in college. Nearly 1 in 11 female and approximately 1 in 14 male students report having experienced physical dating violence in the last year. About 1 in 8 female and 1 in 26 male high school students report having experienced sexual dating violence in the last year. LGBTQ adolescents experience dating violence equally as often as youths involved with opposite sex dating. Youth involved in teen dating violence experience a higher incident of teen pregnancy than their non-abused colleagues, birth control sabotage, STIs, including HIV, substance use, unhealthy weight control, risky sexual behaviors, and suicidality. Other populations with increased risk would be our elder populations. We want to make sure that we're assessing our elders. The elders may be still in a marriage, a long time abusive marriage. So domestic violence or intimate partner violence doesn't stop just because someone turns 70. And I know the current age of elder is 60, but I am 60, and so I'm going to try to ignore that. But the elders might be just have had this abusive relationship for years. So we need to assess for that. It could also be a new occurrence of abuse. So is it some sort of a physical issue that's now changed their mentation, a new mental health diagnosis? Could it be dementia, early onset dementia, some sort of physical condition that could be leading to more aggressive behavior? So you obviously have to check out physiological issues as well. There might be additional barriers for this population to disclose. They might be dependent financially on their partner. Physically, they might be dependent on the other person. They have increased isolation, and just the fact of the long-term commitment with this partner. Obviously, there's other forms of elder abuse that we should have on our radar, things like exploitation or the misuse of their funds or properties, abandonment, which is, desertion of a caregiver, or self-neglect, which is one of the most reported kinds of elder abuse. When they live alone and they don't have appropriate people checking in on them. We also have our populations that have an increased risk are people with disabilities. So the CDC National Intimate Partner and Sexual Violence Survey show that women and men with disabilities are at an increased risk for experiencing sexual violence and intimate partner violence. Women with disabilities are more likely than women without disabilities to report experiencing sexual assault, physical violence, stalking, psychological aggression, and control of reproductive or sexual health by an intimate partner. Women with disabilities have a greater risk of sexual assault than women without, at a percentage of 2 in 5, or 39% of female victims of sexual assault had a disability. Men with disabilities are at greater risk for experiencing sexual violence other than sexual assault, such as being made to penetrate, sexual coercion, unwanted sexual contact with men without a disability than with men with a disability. So 1 in 4 male victims of sexual violence had a disability. Men with disabilities are more likely than men without disabilities to report experiencing stalking and psychological aggression by an intimate partner. And again, there are barriers for this population to report and also to remain connected to resources. So what are some of the physical consequences of intimate partner? Physical injury, obviously, of all sorts. They might not be visible to the public. So when you see the patients for mental health consultation, you may not see any of the bruises. It might take a full head to toe exam or skin assessment, as I like to call them, 100% skin assessment. They might have complications of strangulation that range from the hypoxia to pulmonary issues, brain injury, and injury to the vital structures in the neck. We could have a full hour discussion just on strangulation, but it's important for you to know that it's a very easy way to gain power and control over another person. Just think about when your air supply is taken away and how quickly that becomes a panic situation for you. Research has shown that about 50% of the time there is no visible injury, just the patient or victim's history. And that's if they're asked. So, then that's on healthcare professionals to be the ones to be asking about if there was any pressure to their neck or anything around their neck. It was interesting when I worked as a sexual assault nurse examiner at Hillcrest that once we started asking our patients about strangulation, I was amazed at the number of patients that reported strangulation. So because of the trauma brain, or maybe it was part of their ongoing abuse, they didn't necessarily mention it when they were first disclosing the history of what happened. Multiple negative health outcomes such as heart disease, digestive problems, reproductive issues, muscle, bone, and nervous system injury and disease. Increase in headaches, pain syndromes such as back pain, abdominal pain, chronic pelvic pain, GI disorders, limited mobility, and just plain overall poor health can be reported after ongoing intimate partner violence. And this all makes perfect sense once you understand the neurobiological effects of trauma, right? So there is a life-saving protective release of chemicals when a person experiences a traumatic event. It's similar to an atomic bomb within the body. But when this is overstimulated day in and day out, these chemicals can actually become toxic to the system and cause injury to the different systems of the body. And specifically, we need to think about some of the GYN complications, such as unintended pregnancies, miscarriages, STIs, including HIV. So mental health complications such as depression, post-traumatic stress, and other anxiety disorders, sleep difficulties, eating disorders. I mean, it's a whole list. According to the World Health Organization 2013, women who have experienced intimate partner violence were almost twice as likely to experience depression and problem drinking. So I'm sure I am speaking to the choir. This is no surprise to you. This list is not any different than one for sexual assault, child abuse, or other forms of trauma if resilience hasn't, if they haven't had the ability to heal and have resilience. So patients experiencing IPV do not always report abuse, but they often are treated in the emergency departments or within other healthcare systems. So research indicates that patients are more likely to report if they feel like it is a safe environment to report and if the provider shows them that they have the time to help. So one great story that I have that is just it just amazes me every time I think about it. So I had met a woman who had experienced some extensive intimate partner violence. And she had experienced a pretty horrific physical abuse one day, and she was able to have the children go away, and she got herself to an emergency department here in town. And when she walked in and signed in at the triage desk, the triage nurse said, "That's fine, just go over and have a seat and I'll be right with you." And so the patient walked away, but she didn't sit down because she couldn't. She was that injured. And when she came back, or the nurse went back out to her and said, "You really can have a seat. It's going to be a couple minutes." And she said, "No, that's fine. I'm good standing." That nurse took the time to ask this patient, once she brought her into the triage room, to ask her 3 different times what had happened to her, what caused the injuries that she had today to her back and her legs. And thank goodness for that healthcare provider to take the time and to show this patient that she didn't have anybody else, to take care of, that her energy was all on this patient. And finally, the patient was able to disclose. And that was the beginning of the end for her. It was the beginning of the end of the violence. It was, a new beginning for her. And it was the end of the violence in her world. So it was just a great example of, we as healthcare providers need to take that time and ask those questions in a safe, neutral environment. So what about the kiddos? Well, we all know that, as children and growing up, learning to cope with stress and adversity is an important part of healthy development. And while some moderate short-lived stresses is part of the growth process, toxic stress can result when there's an unrelieved activation of the body's stress management system, and also the absence of a protective, supportive adult who can nourish this child. So according to the Center on the Developing Child from Harvard University, with a supportive parent to buffer the unrelenting stress, children that experience events such as extreme poverty, neglect, abuse, or severe maternal depression can weaken that architecture of that developing brain with long-term consequences for learning, behavior, and both physical and mental health. It's also important to note that IPV affects children who witness it, those who are exposed to violence, household dysfunction, and or abuse. They're at an increased risk for several of the leading causes of death in adulthood, according to the ACE study. And Angelita is going to talk more about reporting of IPV when you do have children in the house or children involved. So many of you, I don't know who's all here, but I bet some of you know my colleague and friend, Tim Bayline. And you may have, well, I don't think he originated this phrase of master of manipulation. He has taught many healthcare providers about the mind of the perpetrator. And I thank him so much for his wisdom. And this is not a presentation on perpetrators. We could be here the whole day. But it is important to remember that the behavior of the perpetrator affects our patients and or our clients' behavior. It is likely one of the key factors to their decision to stay. Abusers are masters of manipulation and need to justify their behavior to themselves, to the victim, and then to others, right? So they have to, they've justified to the victim that it's their fault, that I wouldn't have gotten so mad, I wouldn't have hit you if you didn't do this. And they've also increased their isolation by manipulating and justifying the behavior to others. So you need to listen to this, listen for this when you're working with the patient. Other key components of this cycle of violence are that the abuse is not caused by the abuser's loss of control or too much to drink. It's because they're an abuser, right? And otherwise, if it was caused by too much to drink or just bad temper, other people would also be targets of the abuse. And generally they're not. Generally, it's just the one person. The abuser will decide when the abuse occurs, giving them more power and control. And if the stare or the look does not work to instill fear to the victim, then maybe they'll have to escalate to a slap or a hit. So it's important to listen to for all these things. Victims are all too familiar with this abuse and this pattern of abuse, and they know the signs when the batterer is escalating. And it's a very uncomfortable time for them, and they just wish the abuse would happen and deal with it afterwards. These behaviors are all causes for ongoing trauma. So again, I feel like I'm speaking to the choir about trauma, but individual trauma results from an event, right? The event may be single occurrence or repeated over time. And it's the individual's experience of the event that determines whether it's traumatic or not. Some experiences may be different for each person. Long-lasting adverse effects of trauma may result in the inability to cope with normal stresses of everyday living, trust, managing cognitive process such as memory, attention, regulating behavior, and also such effects such as hypervigilance or numbing. So according to SAMHSA, Substance Abuse and Mental Health Administration, incorporating the trauma survivor's perspective with research and clinical work has underscored the role of traumatic experience in the lives of people with mental and substance use conditions. I thought that was so key for the work that the mental professionals here are doing. The connection between trauma and these conditions offers a potential explanatory model for what has happened to the individuals, right? That's the trauma-informed, what's happened to you, not what's wrong with you. Both children and adults who come to the attention of behavioral health and other service systems. So it's not just behavioral health, it's other systems as well. So I'm gonna play this very short video on resilience and the biology of stress and science. As the narrator identifies, we all need a certain amount of stress to perform well, but if the stressor is continuous all day, it will take its toll.
The reality is that we all need a certain amount of stress, a certain amount of anxiety to perform well. If we don't care about that exam that we're going to have tomorrow, we'll probably fail. If we're going to cross the street and a truck is coming at us, we have release of adrenaline. We have release of a hormone that we call cortisol. We want to jump out of there, and adrenaline and cortisol are going to help us do that. So there's that good amount of stress. But if all day long you're feeling like the truck is coming at you, day after day after day, that's going to take a toll on the body. And the amygdala obviously here has greater activation in the PTSD. We were able to image children that had experienced trauma and compare those brain images with children that didn't have an experience of trauma and didn't have symptoms.
Right, an exaggerated fear response.
An exaggerated fear response with decreased activation in areas that we need to control that emotion, in the frontal areas.
Exposure to early adversity and trauma literally affects the structure and function of children's developing brains. the kid next to them hits them, or the teacher reprimands them in a way that they're uncomfortable with, right? Literally what they're feeling, that activation is like there was a truck coming at them. You can give something that will mask symptoms, right? For example, if someone has a cough, right, you can give them a really strong cough serum that will suppress their cough. But if it's because they have tuberculosis or lung cancer, then what you're doing is merely masking the symptoms while the disease process continues to fester. We know what's happening in children's brains and bodies with the experience of toxic stress. So the question now is, what do we do about it?
So when we talk about having a trauma-informed approach, we need, as organizations and individuals, to realize the widespread impact of trauma and recognize that every patient that you see, every client that you see, has potentially experienced trauma in their past. And recognize what those signs and symptoms of trauma are to not only the clients, but their family members and your staff members, because you guys are working in the field every day and experiencing all these additional vicarious trauma. And respond by integrating knowledge about trauma into the policies of the organization, and by all means to resist re-traumatization at all costs. So I really like that video because it makes me think about, where are we? Are we looking upstream to do some prevention work with violence and toxic stress for the child who's living in an environment of intimate partner violence? So with that, I am going to turn this over to my colleague, Angelita.
Thanks, Diane.
Yeah.
So as Diane said, I'm Angelita Olowu. So I'm gonna kind of continue on. That was a great video. Someone put in the chat that was a great video. It really was a great video to kind of give you some perspective as to what goes on in the brain. It spoke about it from a child's perspective, but the reality is, we're talking about IPV. Clients that are adults or adolescents that are experiencing IV are experiencing the same thing over and over again. They become kind of accustomed to being in that same state of mind as well. So I do agree that was a great video, but take it for that, but also continue on with it. Think about it a little bit further. So let's talk about how this overlaps with the work that you all do. So based on the survey that we did earlier in this presentation, we see that we have multiple different roles that are here presented today. So how that interaction with you and how you respond to it may also look different. But the thing that's going to be consistent for everyone that's here today is that the reality that you are actually encountering people that experience intimate partner violence as your clients on a daily basis in your daily interactions with them. And this could be whether you realize it or whether or not they are experiencing it. So your ability to be able to provide support and adequate resources to the clients that you're providing services to requires that you have some level of knowledge of any previous or ongoing personal violence and abuse that the client may be dealing with. And in order for you to have this information, there needs to be some kind of disclosure to you in some way to let you know that the patient or that the client is actually dealing with this. So it can be that the client disclosed it to you themselves, or it could be that maybe someone else shared a concern or a suspicion that the client was experiencing IPV. How this information is shared with you may also vary how you respond based on your role. So we're going to talk about that a little bit more. So one of the things that I also want to point out to you, which we're definitely going to go into in more detail a little bit later, but there is a recommendation that all adults and adolescents are screened regularly for intimate partner violence. This screening should be provided in a routine manner, and it should be done consistently in a private setting. Any disclosure for intimate partner, with any disclosure for intimate partner violence, there needs to be an assessment of the immediate risk for the client and for any children that may be present. We need to have considerations for those children as well as the safety of the family moving forward as well. We have to recognize that there may be some hesitancy in disclosures, and we also have to really be conscious of the fact that a client may actually deny that they're experiencing intimate partner violence. Most of the time, a patient has to have, or a client has to have a specific place that they're comfortable with you to be able to disclose. And sometimes even when they do feel comfortable with you, it doesn't mean that they'll disclose right away. There may be some additional times that you have to ask before they actually say that they are experiencing this. Next slide, please. There's some additional things to consider. What is your role and what is your relationship with your client? Have they chosen to disclose to you at all? Or are you the person that has a suspicion? So are you providing them services, and as you're talking to them, or you're looking at them, or you're watching their behavior, or maybe something they share with you, maybe you have the suspicion, right? Are you the one with the suspicion that there is, that person is experiencing intimate partner violence? The next thing you have to think about beyond there is, are you the person that's able to screen this client, right? So do you have the ability, the techniques, the resources to actually provide some screening, or is it that you need to connect with one of your colleagues or another agency, maybe someone within your task force or your multidisciplinary team that you already have in your back pocket as a resource to say, hey, I have this client with me right now and I have this concern. Do you have the ability to do that? Or the other thing to think about is that client in an actual situation that's considered acute? So something has happened to them right there. Maybe you are looking at injury to them. Have they had any connection with healthcare, right? Have they had a medical evaluation? So, if you're looking at what appears to be a fresh injury and you ask that person, like, what happened to you? What's going on? And they share, oh, I just fell down or whatever. And you say, have you gone to the doctor? Have you gone to the hospital? And they say no. Do you have the ability to assist them with getting that medical evaluation? Some other things we want to think about include safety. So how did that client get to you today, right? Are they in a place right now where they're feeling safe? You may feel like it's a safe place, but do they feel like they're in a safe place? Is their perpetrator or the abuser, are they sitting out in the car waiting for them? Are they right there in the room there with you? These are some of the things that you have to consider. You want to be able to speak to that client in a private setting. So take into consideration who you have there with you, right? You may ask, is it okay for me to talk in front of that person? And the answer may be yes. Maybe that's not really the way that we should be approaching it. How about we say, can I take you to the bathroom? Or can we speak over here for just a moment and see what the response is? And then be aware of that response. If at that point you can't do that, keep that in mind so that you'll know that maybe there is a reason that we have to be concerned if you can't speak to that person in private. All screening should be done in private. Confidentiality is also going to be a big issue. So your level of confidentiality with your client is important. This is important with all clients, regardless of their age, but it's really important with the adolescents and the youth. I know that Diane kind of mentioned this already. We talk about mandatory reporting. We know that depending on your role, there are going to be things that actually have to be reported. It's important for the client to understand that from the beginning, before they even open their mouth to disclose to you, so that they have options, right? So they have the ability. And so maybe you can also connect them with someone who may have a different level of confidentiality so they can still share. The other thing about confidentiality that I want to point out is confidentiality is also important to think about when you're dealing with young adults and adolescents that may be in a college setting. So what's your role? Are you a part of that? Are you a part of the team responding to domestic violence in the college setting? Are there laws or is there anything governing your level of confidentiality as far as you having to report to the school what's going on and starting a Title IX investigation for them? So just be conscious of what confidentiality means to your client population. The other thing that we really have to hone on is compassion and patience. So we've already said it several times here. making sure that the client actually understands that you really do care about what's happening to them and you're interested in helping them to move forward, whatever those steps are. But also understanding that you have a level of patience with them because they're going through a lot. We just saw that great video, right? Think about having to maneuver that. Think about having to experience the actual violence itself. Think about having to go through their day-to-day activities, and if there are children involved, managing those children, however they're doing that. That's a lot going on. With also understanding the fact that, you know, they may very well be dependent on this abuser for multiple reasons. What if that abuser is the breadwinner and pays all the bills, and, you know, they have no other place to go? We have to keep those things in mind when we ask these questions and try not to be frustrated if we don't get the response that we're looking for, okay? Early on in this slide, I mentioned trying to get the client connected with healthcare for medical evaluation. So if you do have a patient that discloses that they're experiencing IPV, or you have this concern and you want to get them connected with medical, ideally, it would be most beneficial to have a connection with a specially trained clinician to be able to provide them with services, or at least have the patient referred to a sexual assault nurse examiner or a forensic nurse. It would also be beneficial to have a sexual assault nurse examiner or a forensic nurse as a community partner or as part of your domestic violence task force or whatever kind of response team you have set up in your community. These nurses are able to provide comprehensive medical forensic exams for your clients that will include addressing the medical needs of the client, adequate documentation, and providing the patient with resources and referrals for both medical and community needs. It's also important for y'all to consider your own roles with your clients, and that when we think about documentation, what that should look like for you. So, for example, if you are a mental health provider, and you have a client that actually discloses to you that they are experiencing IPV, you want to make sure that you're documenting that. If you see injuries, like they're in front of you in your session with them, and you can clearly see that they have injuries there, you want to document that you see these injuries and what they're sharing with you. Or maybe they report to you that something happened as a result of the intimate partner violence. You want to document the report of that injury. And then if you personally have any concerns or suspicions, regardless if the client is denying it, you want to make sure that you're documenting that as well, that, you know, you do have these concerns for this client. Next slide, Diane. So I would like to pose a chat question for you all. If you can go ahead and throw into the chat, if you would mind, some of the methods that can be used to identify and support clients that experience intimate partner violence. And while you do that, I'm just going to keep talking for a little bit. So I kind of touched on the fact that, you know, you may have times when the person may disclose and you may have times that they don't disclose. So one of the things that I want to kind of remind everyone is that it's very difficult for people to disclose that they have or that they're even currently experiencing intimate partner violence. And I know you guys already know this, but I want to talk about it a little bit more. So this applies to both intimate partner violence as well as sexual violence. We know that they're both very personal in nature, right? And they often overlap, right? So we can have patients that may come in specifically to be seen because they've experienced sexual violence. And then as we go further into the exam and learning more about what's happening, we'll learn that this sexual violence actually was a part of their intimate partner violence. And the same thing happens when we're working with patients that were, or clients that were specifically assessing for intimate partner violence. We'll learn that part of the violence that they're regularly experiencing is sexual violence. So that overlap is there and it's continuous. But we have to be able to allow them space and time to get to a place where they're most comfortable with being able to make the choice to disclose these things to us. There's so many dynamics that of course we're not talking about today, but there's so many dynamics regarding IPV and sexual violence that we want to make sure that we understand that the goal is not to gain a disclosure, but to assess the client, educate the client, and make sure that you have resources available to offer them whenever they're ready to utilize them. you want that client to know that they can trust you, right? You want them to know that when the day comes that they're ready to give a disclosure, that they can come to you. And it doesn't matter if they decide at that point, no, I'm not disclosing anything happened to me today, or yes, I am. It doesn't matter how they decide to respond. Your goal doesn't change. You still want to make sure that you're doing those same things, assessing the situation for them, making sure that you're providing them as much information as you can to keep them safe, making sure that you're educating them on things like dangerousness and how to watch for increase in dangerousness, and helping them have resources. So when they do have the nerve or the courage or think it's the right time for them, they know what to do from there. Okay. Oftentimes you will see that the resources are accepted, but they're not utilized. That's fine too. Be okay with that, right? Because you know that you've given them what they need. And again, when they're ready, they'll have it there. Just because they haven't told you that they're developing that plan doesn't mean that they're not doing it. Don't become frustrated. Don't become angry. Just continue to be consistent. So I'm gonna just look in the chat real quick and see if we had anybody put anything in.
Yeah, so we did have a couple comments. I just changed the slide too, but observe, listen, ask open-ended questions, provide a safe environment, meet them where they are, which is what you just said, Angelita. That's great. At that moment, in that space, in that time, no judgment. It's important for them not to feel alone in this. IPV is unfortunately common, and there are others who are going through this and have been through it in the past. It's important for them not to feel judged, and offer empathy and safe spaces are all great answers.
Yeah, these are really good answers. Thank you guys, all that put stuff in the chat. I want to just piggyback, I believe it's Emily, for her thing about knowing that it may have happened in the past and that there are other people who are experiencing it. When Diane talked about making sure that we think about our elders and their experiences, I just want to tell a quick story of a patient that I had who was actually an elderly patient. And when I asked her, about what was going on in her situation, she actually began to cry. And she wasn't really crying because she didn't want to share or because she was afraid. She was crying because she said that no one had really took the time to ever ask her. And she had been experiencing intimate partner violence with her significant other for years. And as part of her exam, as in her older years, everyone just kind of thought everything was fine, and she was still experiencing that level of violence at home. And it was like that was just part of her world. She had begun to just accept that this is what it was going to be. But when we took the time to talk to her about what was happening and how she felt about it, that she felt relieved. That's what she kept saying. She felt relieved that someone actually took the time to ask her about what was happening and to help her understand that that didn't have to be a part of what she was experiencing for so long. So just another takeaway, doesn't really matter about the age of the person. Just keep in mind that sometimes we aren't asking the questions in a way that allows people to open up. So oftentimes we're asked the question, are you safe at home? What does that really mean? What does it mean, am I safe at home? Does it mean that I'm on a trip? Does it mean that I have lights on? Like, what does that mean? We can't always assume that safe means the same thing for each person. So moving on. What happens if the patient actually denies that there is no abuse or that there's no indicators of abuse, right? What happens when the patient is saying, nope, not me? Well, first thing I'm going to do is respect their response. We've talked about that already. I think I honed on it enough. We're going to let the patient know that we're available if the situation changes. And so I'm saying we, because it doesn't matter what your role is, just letting them know that, hey, if you ever want to talk about something or something comes up that you have questions about or you want a clarification, that you're accessible to them, right? Making sure that that client is actually being assessed continuously, like we talked about in regular intervals. Display information and resources in the exam rooms and waiting rooms in the bathroom, right? And then also thinking about if you are in a provider service where you're actually giving things to the client, thinking about it before you give it to them. So having the conversation about, hey, I have this information that I want to provide you, but I want to do it in a way that's going to be safe for you. So how can you give it to them so that they will still be able to access it and not have it found or not have it taken from them or not put them in a more vulnerable situation that's just based on you trying to provide them with information. Indicate your concerns for their safety and then specific risk factors or any kind of other information and resources. Discuss with the client any available resources for help and possible repercussions if the patient finds a card. We talked about that. And then we also talked about not writing domestic violence referrals on the discharge paperwork. So not just not titling it that you were seeing here for this, that, and other, but also not putting those actual referrals that you are providing them and resources that you're providing them with on your discharge papers. So the U.S. Department of Health and Human Services has endorsed that the Institute of Medicine's recommendation of intimate partner violence screening and counseling be a core part of women's health visits. So I'm bringing that in because that's important for you all to know that this is something that healthcare providers are encouraged to do, but they're encouraged to do it like as far as women's health, but we need to be encouraging people to do it for every client, every patient in a manner that you're able to, right? Because like Diane said, it touches across the lifespan. It's not one specific gender. It's not one specific sex. It touches everyone. So we really want to be conscious of doing this on a regular basis and knowing that there's a variety of screening tools that are available, making sure that it's routine for all clients, making sure that people with disabilities are being provided with screenings for their caregiver, like screenings to know if their caregiver are actually people that are abusing them. So when we have those clients with disabilities and the caregiver is always constantly present, take that time away from that caregiver to be able to do that screening and keeping in mind that the caregiver potentially can also be an abuser. And we also need to understand that all screening tools are not the same and don't screen for the same type of abuse. So looking at the various screening tools, adapting that screening tool to your population would be the best recommendation. And also noting that all tools have been evaluated, not all tools have been evaluated for all patient populations, right? And this kind of goes with all kind of things for medicine. There's so many things that were built up specifically upon a specific, maybe we say a white woman, and they're trying to be adapted to fit a male or to fit African Americans, and it doesn't always work out the same. So just be conscious of that and understand that sometimes you may have to modify the screening tools that you're using. So the danger assessment helps to determine the level of danger that an abused person has of being killed by the partner. It's been adapted in many settings to be used with many different patients. I'm going to say patients for this particular slide. But in its original form, it was created to address the cisgender woman or a female sex assigned at birth that identifies with the sex. And specifically, these women are being abused by men. So this assessment is freely available to the public, but should be administered by those that have been properly trained to conduct the assessment. So using the danger assessment requires the weighted scoring interpretation that is provided after completing the training. The danger assessment is available in a variety of languages. So this is a very important assessment, and I am sharing it here mostly because there's not another one really that I know of. Diane, please feel free to speak up, but I don't know another one that's actually kind of built up the same exact way this one is. But again, this is what we're talking about here, where you have to sometimes do modifications because again, as I said in the last slide, this was created specifically for one set of population, but we have to use it for others. So the other thing I wanted to take away here was just regardless of which tool that you do choose to use, and whatever the results state, is really important for you to remember that your client is the one that's going through the situation and they know their situation best. And so they're best going to be able to inform you on the potential lethality of their situation. And always keep that in mind when you're working with your clients, that they know their situation, they know their abuser, they know what they need. So hear what they're telling you. So previously we mentioned that screening should be conducted in a private setting. If the initial screening is not done in this manner, it should be revisited in another setting where you can be alone with the client. And then the only other thing I really want to point out here is we kind of talked about it a little bit before, but just knowing that strangulation should be a regular part of the screening. Diane touched on strangulation a bit earlier, but it's really important for clients to be assessed because oftentimes they don't necessarily know how dangerous strangulation is. And it could be because they're so used to that being a part of their abuse, but sometimes it's also that they're used to seeing it happening to other people. So we know strangulation is a part of a control thing, right? And so if this person I'm seeing happen to them all the time and nothing has happened to them, it's okay that it's happening to me because nothing has happened to me at this point either. So it's not even just about also assessing, it's also about educating how dangerous strangulation really is. So we are almost out of time, so I am going to kind of fly through this last few slides kind of quickly. This one we're going to talk about reporting. So we really want everyone here to kind of walk away understanding from a healthcare perspective what's the most, I don't want to say the most important thing, where mandatory reporting falls in line there. So for healthcare providers, they're not required to report abuse to law enforcement or legal authorities unless their patient presents with injuries related to gunshot wounds, stabbings, second or third degree burns, serious injury, and child abuse or elder abuse. So that's important for everyone to understand because as I said to you earlier, we want to make sure that a person that we know experiences abuse actually has a medical assessment done. And sometimes when people make that referral, they also have the assumption that the medical providers are going to call the police because this person experienced intimate partner violence. But in order for healthcare providers to be making that mandatory report, they have to have these certain circumstances occur. Okay, so we just wanted to make sure that that was really clear and upfront so that the assumption didn't exist. So Diane talked about the children who witness violence. There are some laws around that, and there's some law specific or legislation specific to teen dating violence. So for the child witness, what the Ohio Revised Code tells us is that an offense is committed in the vicinity of a child if the offender commits the offense within 30 feet or within the same residential unit as a child who is under age 18, regardless of whether the offender knows the age of the child or that the offense is being committed within 30 feet or within the same residential unit as the child, and regardless of whether that child actually views the commission of the offense. Right? So the other thing that we have to think about is, are there other resources for children who witness violence, such as children who witness violence, right? In Cuyahoga County. And I think, does that cross into Lake as well, Diane? Children who witness violence program?
I'm not sure if our Lake County folks would know, probably.
Well, just know if you have other resources aside from automatically making a report to Child Protective Services. So I talk about children who witness violence, just in case you guys are not familiar with that. In Cuyahoga County, there is a particular program that was created just for this scenario. So law enforcement actually makes the call when they go into a situation, IPV, and there's a child there. They'll connect that family with children who witness violence as a resource instead of just automatically making that call to Child Protective Services. Teen dating violence. So House Bill 10, Civil Protection Order against minors who present threat or danger. Then there's House Bill 19. This one is for minors who do not have confidentiality. Oh, I'm sorry. House Bill 19 is specifically around dating violence prevention. So the thing that we have to keep in mind is that minors don't have confidentiality around issues of physical or sexual violence in the state of Ohio. And providers should make sure that the patient is aware of those situations and those limitations, as I stated already. Oftentimes you do have to remind a minor that. So when you're working with those adolescents, especially when they do become comfortable with you, just making sure that throughout the visit you are reminding them of the different things that you would have to report. And then the other thing you want to think about is the fact that their guardian or their parent may also be able to obtain their medical records because, you know, there are the guardian and the medical providers in the medical healthcare system.
Angelita, we're at noon, so we will get the rest of this PowerPoint over to Nicole and Liz, and it can be sent out. We do have, so we need to,
Angelita actually already sent me the updated PowerPoint, so we will definitely get that out.
Okay,
If you could
perfect.
send over, I know someone had requested the
Danger.
the danger assessment. So if you guys
Liz
could
already
send
put
that
it in.
over.
Yeah, Liz put it in. I
Sorry.
had said it's accessible online.
Sorry, thank
Yeah,
you.
so I can add that to everything that we send out as well, because it is a downloadable PDF. So thank you for sending that. And it was relatively easy for me to find very quickly.
Yeah,
So-
it's easy to find. Yeah.
Absolutely. So
Great. Thank you,
Thank you
everyone.
very much.
Thank you.
Okay.
Enjoy
Thank
the rest
Thank
of
you.
the conference.
absolutely. And thank you both for presenting as well. So just so we are staying on topic, the session code for that presentation is IPV, and those are all capital. So Nicole, if you wouldn't mind dropping that in the chat as well. As we bring in